Thank you all for being with us for season 6, episode 11 of Doc Talks with Dr. Forrest, Tennant, and friends. We are on our Giving Thanks special, and we're giving thanks tonight. We have a lot to be thankful for and a lot to look forward to. Dr. Tennant, please take it away. It's all yours. Thank you, Doc.
Thank you very much. I guess if we're all set to go, we're going to go. We
Yes,
have a great
sir.
program lined up tonight. And it's very full. We've got a great guest that you're going to find here for some very interesting things on. Pat Irwin is here with our special project with the medical board. And then I've asked Dr. Ibsen and Dr. Guest to have their usual profound remarks. So first thing I'm going to talk about is, might surprise you, we're going to talk about pregnancy. So you might say, what's pregnancy got to do with what we're talking about? It has a lot to do with it because it has been studying the pregnant woman that has given us some ideas about pain relief. And what I want to talk about in the next few minutes is some studies of mine, which really have grown out of the whole project to try to find for people some alternatives to opioids. Because people are having trouble, as you know, getting opioids, enough of them. Some are being forced tapered, some can't get supplies. And we're going to talk a lot more about that tonight and also in the future. But so what's the pregnant woman got to do with that? It turns out that the pregnant woman has two hormones to get through pregnancy, and those hormones are the equivalent of opioids. Now let's talk about the first one. When a woman gets pregnant, her uterus obviously starts to expand and it hurts. And so what happens? The good Lord has given the placenta the ability to make a hormone called human chorionic gonadotrophin, more abbreviated HCG. And let me just say right out front, anybody who's got chronic pain, particularly bad enough to take opioids every day, needs a trial of HCG. To me, it's almost an essential hormone to be tried by everybody with severe intractable pain. Now, why is that? Well, human chorionic gonadotrophin is the God-given natural hormone that allows a woman to expand her abdomen several sizes and not die in pain. Now, if it'll do that for the pregnant woman, it ought to do this for some guy who's got adhesive arachnoiditis or CRPS. And it does. It's just that people don't know how to use it or how to get it. But we're going to explain that to you a little bit. Now, human chorionic gonadotrophin is so valuable to pain patients for two reasons. And that's because it's actually two compounds rolled into one. Biochemically, it's comprised of two amino acid chains. Now, one of those chains is the exact hormone that causes in your body other hormones to increase. In other words, HCG causes your estrogen, your progesterone, your testosterone, and your thyroid to come up to normal levels. So we know that chronic pain and opioids themselves deplete these hormones. And when you take HCG, they come back up to normal levels and you get the benefit of several hormones when you take just this one. Okay. Now, the second chain is very interesting. The second component of this hormone is for pain relief and to regenerate nerves. In the embryo, it's the thing that generates the brain, the spinal cord, and the nerves. It is the body's own natural nerve regenerator. So if you have a condition such as multiple sclerosis or such as adhesive arachnoiditis or CRPS, you certainly want to be having trials of HCG to try to regrow damaged nerves because that's what it does. And so I highly recommend that for people. Now, how do you get it and how do you use it? Well, there's off and on, it's been restricted in the country, but right now FDA has allowed it to be obtained, and you obtain it through compounding pharmacies. I'm going to ask Dr. Guest later to talk a little bit about what we call a compounding pharmacy. Now, every pain patient in the country needs to know what a compounding pharmacy is and needs to know how to access one, because you have to go through a compounding pharmacy to get certain things you need. particularly HCG. A couple of things about dosages and how you use it. You start off either dropping it under your tongue as a liquid, or you can take an injection. You start off taking 500 or 1,000 units in a single dose 2 or 3 times a week, and you can increase it as you need it. A trial is 3 weeks. You want to try it for 3 weeks and see if you get a response. During that period of time, you'll find out whether it reduces your pain or whether you think it's regenerating some of your nerves. And I don't want to get anybody's hopes up too much, but we've seen people reduce their opioid dosages 50%, 70%, and we've seen a lot of great things from this compound. It doesn't work in everybody, nothing does. However, it works good enough and is consistent enough that I believe everybody should try it, particularly those people who think their opioid supply may be threatened. You need to know about HCG and figure out real quick how you get it. That might be your lifesaver. Now let's talk about pregnancy hormone number 2. Pregnancy hormone number 2 occurs at the time of birth. Now, when that baby decides to be born, in order for it to leave the uterus and pass through the vagina and be born, it's going to tear a lot of tissues. I mean, the doctor may have to cut some tissue to get it to baby out in the first place. But delivery is extremely painful. How do you live through it? You live through it because the good Lord has a compound called oxytocin. It is a hormone that's a pain reliever. In fact, it is the only hormone in the body that's a pure pain reliever, and it has the potency of opioids. Okay? Now, and why it's not used more, I think it's because people don't know about it. But oxytocin is made even in people who are not pregnant. It's in the blood of everyone, and it's there to go up in levels if you have severe pain. They say it's also the love hormone. I don't know if that's true. I've given oxytocin to a lot of patients, and I've gotten no more kisses than usual. So I can't vouch that oxytocin is the love hormone, but they call it that. Okay. But anyway, oxytocin, you can get it compounded, usually made in about a 20 international units troche to go in the mouth or under the tongue. It can be a liquid or something that goes in your mouth. You don't swallow it. You can get it by injection, but it's usually made by a compounding pharmacy. That's what they call a troche or a liquid. Dr. Guest may explain some of that a little later. The dosage is starting off with usually about 20 units, but it can go up to 40 units. You take it just as if you were taking any breakthrough medicine or flare medicine, and you take it and it lasts about 4 hours. Okay, and it's very potent. Now, what I want to tell you about is a study I did at one time, because I had patients who couldn't get opioids. I had to find something potent as fentanyl or as potent as OxyContin. So I did an experiment one time. I got a group of intractable pain patients, and I gave them oxytocin. 15 minutes later, I gave them a dose of ketamine, again, about 20 milligrams. And to a person, these people who were very experienced opioid users said the combination of oxytocin and ketamine was as potent as any opioid they'd ever taken. Now, all you folks out there who may be threatened with your opioid dosage, you need to know that the combination of oxytocin and ketamine is powerful. Both of those can be made by your local compounding pharmacy, and the cost may be, I don't think it's not cheap, but it beats not having an opioid or having any pain relief. Bottom line is this: if you want non-opioid pain relief, I know of nothing more potent than a combination of oxytocin and ketamine. The two together will give you great pain relief, and it'll relieve all your withdrawal and at least give you temporary pain relief. And I'm encouraging everybody in the pain field, every doctor, every therapist, to understand that we do have some alternatives, but you got to know what they are, what they do, how to take them, and you've got to go to a compounding pharmacy. One other thing I want to call to your attention: we've got a lot of people these days who don't want to take opioids. we've got a lot of people out there these days on low-dose naltrexone, taking oxytocin with low naltrexone as a dynamite pain reliever. And it's non-opioid. You can't get dependent upon it. And so for all of those of you who don't want to get into opioids, low-dose naltrexone plus oxytocin is a dynamite combination. Give it a go. I'm going to ask Dr. Guest to say, how do you get in touch with a compounding pharmacy? How do you get your doctor to order these things? People need to give them a try. Anyway, we're going to shut off the educational program now and get into an interview that I think you're going to find fascinating. I have asked a patient and a good friend of mine, Mike Seidel, to come on. Mike, I see you there. You about ready to come on?
Sure, Doc, whenever you're ready.
Great. Now, Mike is a fairly new adhesive arachnoiditis patient. And frankly, he's kind of gone off on his own. He's had the temerity and the willingness to experiment. And what I want you to do, Mike, first off, let's talk a couple of basics. Where do you live, first off?
I've been in Baltimore County, Maryland.
He's in Maryland. And when did you get arachnoiditis?
Well, to pinpoint it is difficult to say, but I had spinal fusion in February of 24, and it wasn't long after that when I started having symptoms. Tried to tell my neurosurgeon about it, and he just kind of said, "Oh, that's normal," and waved me off. Wasn't long after that, it came to around June of 24 that I went and saw my hip doctor because I thought my hip was going up. And he said, "It's not your hip, it's your back. I'm going to prove it to you. I'm sending you for an MRI." Thank God he did. I went and got an MRI, and the radiologist is the one that picked it up and said I had arachnoiditis. Then I went back to the neurosurgeon and said, "What is this?" And he kind of sheepishly said, "Well, yeah, we did it, but there's no treatment and there's no cure, so see ya."
No cure, so just see you. Sent you on. Didn't give you any medicine, didn't give you a prescription, didn't do anything.
Nope.
So what happened after that?
Well, then I started researching, trying to find doctors that treated it. And I couldn't find any until I found you. So I went, after you gave me some protocols to follow, I went back to my primary care, showed them to her, said, "Look, this is simple. All you have to do is do what he said. Give me these 2 shots of the corticosteroid, and I forget what the other one was." She wouldn't do it. She wouldn't even look at it. I gave her all the information. She never even acknowledged that she got it. She did send me to a neurologist, pain doctor, basically. And all he wanted to do was treat the pain. And I tried to explain it to him. "Do you know anything about this disease?" "No." "Do you want to know anything about it?" "No." All he wanted to do was give me epidurals, which I'd had before. And I said, "No, listen to me. The root of the problem is that my nerves are being pinched off. And if you know anything about this disease, it can get more serious than that. I've already had some other neurological symptoms. My gut's messed up. And all you want to do is treat the pain. You don't care if I wind up in a wheelchair. You don't care about anything but making money." So I gave up on him, and you put me on to several things that have worked miracles for me. PEA is the first one. I'm taking 1,200 milligrams in the morning and 1,200 at night. Then you gave me DHEA, 100 milligram, and I'm taking 2 of those in the morning. And the really good one is the glutathione. That's a hard word to say. That's 500 milligrams, and I take 2 of those in the morning. In addition to that, I found, just by trial and error, this stuff, and I sent it to you, Doc, if you remember. It's made by a company called Research Verified, and the product is called Nerve Support. And it helps to rebuild damaged nerves. And it's helping me. I take 2 of those a day. And then I also take over-the-counter stuff, turmeric and curcumin, and another one that's helping build up my testosterone level was low, so I'm building that back up, and it's making me stronger. Because one of the effects of this disease was my legs were getting weaker and weaker no matter what I did. I was going to the gym, I was working out, nothing was working. And nobody seemed to have anything to do. They sent me for physical therapy. Of course, that didn't do anything. The only thing that helped me, Doc, was finding you. So that's my story. And I'm now to the point, I was walking with a walker before. I'm back to walking with a cane now. I'm getting stronger every day. I'm going to the gym 3 days a week and using a therapy pool and a hot tub. And hot tub is the best thing in the world. But I was really concerned because I was really starting to slide. And God bless you, Doc. You came up with the right word.
What's happened with your pain now?
What pain? I
So
don't have
when-
it anymore.
Don't have pain anymore.
Nope.
When did it disappear?
It hasn't disappeared completely, but it's down to about 99% gone. Most of it was in my my lower back and into the gluteus maximus on both sides and down the leg. I still get cramps in my my calf muscles in the left leg, but that's been going on ever since the back surgery. So I can't blame that on the arachnoiditis, but that's even getting better.
So at this point, you're not taking any opioid drugs, no steroids.
I did it first. I took tramadol, which worked miracles for me in the beginning, but I don't need to take anything now. But occasionally I'll take a Tylenol. That's it.
Now, the reason I wanted to have you come on here, this combination that you're taking scientifically makes a lot of sense on why it may work. Maybe something that everybody should be doing, because I'm going to kind of analyze each of these things you're doing right now. But you said something interesting a while ago. You thought the glutathione was quite effective for you.
Yes.
What did it do for you?
I'm not sure. I think it's the combination. The DHEA, the glutathione, and the PEA. That combination in the doses that I told you, which you told me to use, and that nerve support thing that I found, have just worked miracles. And I don't want to try to separate them out and tell you which one worked better because I don't know.
Yeah,
You're the expert. You told me.
All right. Well, Mike, the reason I wanted you to come on the program is that I have thought for some time that there's got to be a combination of things that work. Now, we've advocated for, as you know, many years, what we call the 3-component treatment. Now, the things you're taking fit that model. You're doing something for inflammation and autoimmunity. You're doing something to regrow tissue, and you're doing something for pain relief. Okay?
Mm-hmm.
Let's talk about each one of these for just a second. PEA,
okay.
You're taking that 1,200 milligrams in the morning and 1,200 at night.
Correct.
That dosage, it's got good pain relief. When you started taking it, did you notice pain relief right away?
Almost immediately.
Almost immediately. Okay, so you're doing that. Now, what PEA does scientifically is a couple of things. We think the major thing it does is work in the brain. We think it actually restores glial cell activity, which is necessary for pain relief. That's why even though it doesn't give you immediate pain relief, you got immediate pain relief, which is good, but it gives you some delayed pain relief. So now
within a week or two, it really did.
Okay, so we've got that. Now let's go on to DHEA.
Okay.
DHEA is actually made in the brain and in the spinal cord, and it's actually a hormone that makes about 4 other hormones. It makes estrogen, testosterone, progesterone, and probably some nandrolone. And so when you take DHEA, you're taking several hormones at one time, all of them known to regenerate nerve tissue. And for those who are quite scientific, DHEA is the one, what we call neuroregenerative hormone that has double-blind controlled studies. And most of these were done with lupus patients. But a dosage, you got to have at least 200 milligrams a day. 200 to 400 milligrams a day has been shown now in multiple scientific trials to relieve pain and regenerate tissues. So we've got two of the three down. Your PEA is going to give you pain relief. Your DHEA is going to regenerate nerves. Now let's talk about glutathione. Glutathione is a peptide, but it has tremendous anti-inflammatory and autoimmune characteristics. So we do know that it cuts down a lot of inflammation. You may have struck upon a combination, Mike, is one that everybody should start with. And I'm not saying it's going to be as effective as methylprednisolone and ketorolac, but you're certainly doing well with it, and people ought to try.
I would have been happy to use those, but the doctors wouldn't give them to me.
Wouldn't give it to you. Yeah.
Nope, they refused.
What do you give me your assessment of the medical profession after what you've been through?
Do you really want to hear that?
Yeah, I think we need to hear it.
I think they're in the pocket of Big Pharma, and if Big Pharma tells them don't treat anything that would cure somebody, God, we can't make money that way. So they won't. They wouldn't even acknowledge it when I gave it to them. I gave them all the research that you gave me. I showed it to them. They wouldn't even acknowledge that they got it.
Yeah, besides yourself, you got a lot of people out there who are running into the same thing. What's your recommendation to them?
To find your foundation and get started with your protocol, because it works.
It works. All right. Well, we got what we're going to call the triad: glutathione, DHEA, and PEA. Looks like a winner to me. That may be the combination that people should start with. There's good scientific rationale why it works, and you're a good example. In other words, you're one of the very few people I've ever known with arachnoiditis who can sit here and say your pain's gone. I mean, do you realize how unusual you are?
I realize that, and I'm extremely lucky that we caught it early, Doc.
You bet. I want to ask here if Dr. Guess and Dr. Ibsen, either one of you guys want to chime in and ask some questions? Mark, I see you got that quick look on your face.
Mike, this has not happened yet, and it may never happen again. So I want you to hear this. I apologize to you for your abandonment by the medical process. Now, I didn't do the abandoning, but somebody owes you an apology, and I'm going to give it because why not? So all of you who've been mistreated by a medical system that's taken over by superstition, I apologize to you all too. And my commitment is to resolve this gap in curiosity. And that once again, we can return to a medical system where we're scientists instead of tools used by someone else. It's a very authoritarian. You basically experienced no soup for you in an arbitrary way, and that is not acceptable, never has been, and it's back to the dark ages, and we're getting out of there. Thanks.
Yeah. The thing that angers me the most is when I went back to the neurosurgeon after I got that MRI report, and he acknowledged that they did it, to tell me that there was no cure and no treatment, and not tell me what he knew about it, because they had to have experienced this before. They're the ones that do all the back surgeries. Can't tell me that this doesn't happen more than once. They know what it is. They know what it can do. They didn't even warn me what I should be looking out for. Not once. I had to find that out on my own. And when I saw it, it scared me to death. And I was so glad that I found Dr. Tennant.
Well, as soon as word spreads, their business is over.
These people don't give a damn.
Sue him.
You can't. Got a comment or two?
Paper one you can't get them.
No, not yet.
Not yet.
See, I see that Allison Guyton's here with us. Allison? Can you hear me?
Yes, I can. I'm here.
Give us your comments on Mike's case and the medical system, whatever you want to comment on.
Yeah, I was going to say, the doctor flat out said that he caused it with his surgery, that I would pursue malpractice and sue him for
Yeah,
getting,
you forget I live in the state of Maryland. They don't let them sue you for anything.
well,
Sign a release when they did the surgery that says if they kill you, you can't sue them.
gotcha. Yeah, they have you sign on the dotted line, but
And Maryland also has a limit. If you did sue them, Maryland has a cap on it. You can't get very much money out of it.
yeah, you'd end up wasting more money on lawyer fees. But
Yep.
thank goodness that you caught it early enough so these herbal supplements are able to reverse it for you.
Can't believe how grateful I am.
Absolutely wonderful, because I went 30 plus years without a diagnosis, and as soon as I found Dr. Tennant in my primary care, did the therapeutic trial with the Medrol dose pack and the Toradol shot, it was within 24 hours the difference of night and day. I went from 2 hours of sleep and horrific pain to actually a straight 6-hour night sleep.
Yeah, well, if it hadn't been for my hip surgeon having me get this MRI and telling them to look for anything, I would have found out.
Yeah.
Because they would have told me never.
Yeah. And you're lucky that the radiologist was able to read it, see it, because they usually miss it.
What my symptoms were, oh, that's normal. No, it's not. No, it's not.
Right.
He lied to me.
As soon as I found Dr. Tennant's material and showed up at my pain management doctor, who I had been seeing and getting epidurals and facet joint injections and all that for 10 years, and showed up with paperwork on adhesive arachnoiditis, they found a way to get rid of me right quick.
Isn't that convenient?
Yes. So I changed pain management doctors, and he is very compassionate and knows all about that other clinic. As you said, follow the money trail. All they do is the invasive procedures and don't want to actually help you get better. But my current doctor does, thank the Lord. As you said, Dr. Tennant saved my life just as he saved yours.
Yeah, I even did stem cell therapy, and it didn't help either.
Yeah. Mike, thank you so much. We are so delighted that you've been willing to share this. And frankly, you may have struck upon a triad of medicines that a person can buy without a prescription and without a doctor, and maybe
got them all from Walmart, Doc. Believe it or not.
There you go. It could happen anyway. Congratulations. Hang in there, buddy. We'll work on together. Okay.
I'm indebted to you forever, pal. You need me anytime, I'm available.
Thank you,
man. We'll be calling on you. Thank you so much.
You're welcome.
We're going to move on now to the next part of our program today. And Pat Irving is going to come on and talk about the medical board project we're in. But to introduce her today, I want to tell you about a case I was consulted on this week by a California physician. And this physician had a patient he wanted to get my opinion on, mainly because he was worried about the California Medical Board. And now let me tell you about this patient. She was a lady in her 60s, and she was a woman of color. And I point that out because some people of color have one strike against them already in trying to get some help. And given her history, I can see why she would. At any rate, the lady, some 15 years ago, developed severe pancreatitis, almost died, and the pancreatitis never went away. She still has to this day some abdominal pain. Now, it wasn't too long after she had her pancreatitis that she developed sarcoid. Now, that's a pretty rare disease, but it eats your lung alive and also some of your ribs. It's very painful. So she develops sarcoid. Later on, of all things, she develops an autoimmune disease like lupus and has all kinds of pain in her muscles and her joints. In other words, she's got multi-system pain disease, And the reason the doctor wanted me to see her, she's taken an unusual regimen. She was taking low dosages of both oxycodone, Vicodin, and tramadol. It added up to about 150 milligram equivalent a day. And he wanted to know what to do about her because he was worried that the medical board wouldn't understand her disease or the fact that she's above the 90 milligram equivalent recommended by CDC. And of course, my answer was, you can't take this lady off that. She survives all this time. 150 milligrams of morphine equivalent is nothing. The regulations say she's entitled to it. Clinically, she's entitled to it. And medically, she needs it. And so leave her right on it. So that was my consultation. But the point I'm getting at, I think the doctor was very justified in worrying that the medical board finds out about a case of somebody taking 3 different opioids, even at low dosages, has all these unusual diseases, and they'll hire some clown consultant who's never treated any of them and wouldn't know a thing about this and say how terrible this is, needs to be taken off her opioids and the doctor disciplined. That's I can see why the doctor is concerned. But the point I want to make is, my guess is that there are so many people in pain clinics today that have multi-system pain disease. They don't just have one condition, they have multiple systems, because we now know that so much of severe pain is based on autoimmune disorders, probably activated by viruses, maybe sometime even in their childhood. So we're developing science way beyond where medical boards are at. And just because somebody needs 3 low dosages of an opioid, yeah, that's unusual, but it works. It's cheap and it's simple and it's safe. And anyway, that's what we're up against. And so Pat Irwin is here and to tell us about how we're coming along with the medical board issue, because I saw, again, the case I consulted on this week, it tells me that's where doctors are at today, and they're justified in being worried about bureaucrats coming in and looking at a case like what he asked me about. Anyway, Pat Irwin, are we here?
Yes, I'm here, Dr. Tennant.
Okay.
No,
All right, the rest of the program is your and Mark's to tell us about medical boards and try to help us save a few people. Okay?
Thank you so much, Dr. Tennant. There are still many challenges, as you have alluded to, Dr. Tennant, and we cannot let up on the medical boards, not in any state, not in any way. And I thought this was a really good time to kind of summarize where we've been over the last year, what our group's accomplishments have been, some key findings, and really where we need to go. And after that, I'm going to turn it over to Monty to talk about the pain forum that's coming up. But first, let's look at, we have done some good with our work. And I keep referring to Washington State, but they are moving forward with reviewing their guidelines, and they have hit, they hit their hiccups here and there and bumps in the road, but they're moving forward. And I know Maria is always help and consult with any of us if you have questions. There was some progress made in Texas. Andrea Anderson presented to the board and kind of got them to agree to start looking at working with the pharmacy. We know Dr. Ibsen has done amazing work fighting his battle in Montana. And that's nothing we have individually done, but that he and Susan have really led the fight there. And we have got to keep supporting them every time that comes up. Last but not least, we have California. We do have a little victory. We know with Dr. Haddadin that his the allegations that he had were cleared. So that was a huge victory. And there was a lot of findings that we got from that I think will move us forward. So that's kind of the progress that we've made just in, I'd say we started in June. So really we've only been officially working on this for 6 months. So I would say we have, a lot to be really proud of. In terms of key findings, I want to say one of the big things we learned, I want to pass on to people, is don't forget your medical associations. Like in California, it's the California Medical Association, and there was one in Washington State. And the reason I say that is what Maria found in Washington was she had agreement to go forward with these guidelines, and it wasn't physicians on the medical board that pushed back, but physicians in her medical association. So this was very interesting, and it just a heads up to people. If you do get far enough to start working with your board, be sure to do some research and query your medical association. In California, we're lucky they have been supportive of our guidelines, but that's not the case in other states. So I would say really pay attention to that. The other finding was you cannot be specific enough about how the board is going to judge the case. And let me be really clear on what I mean by that. In California, if the case goes up for review, they look at either finding one major discrepancy or two minor ones. And you can argue what those are, but knowing that ahead of time, you would know as a physician or a patient how to word either your defense or your offense on this particular case, because you would know exactly what does the Medical Practice Act in your state say. You have to know, what does that Medical Practice Act say? And another key finding I can't emphasize enough is use Perplexity AI. Use AI when you can to find out who are your board members, how have they voted, what are their phone numbers, what are issues important to your state. It's so much easier now that you can get really deep information that you couldn't get before. Doesn't cost. Entry level, you can ask 2 or 3 questions on Perplexity AI before it says, boots you out and says, try again. Well, so fine, you go back in. So you don't have to pay. I use it every day, 4 or 5 times a day, and have not had to pay for it. So those are kind of some key learnings that we've had. That brings us to where are we going to go from here and what are our challenges? And off the top of my head, I'd say we don't have a broad enough push. We have action in those 4 states that I mentioned, but nothing else. And I know, we all know that everyone is struggling. It's a given. But I do want to push our group a little. We have 851 members in Doc Talks. It's huge. That is huge. 851. And even if a quarter of us have intractable pain or can't write a letter or can't make a phone call, that leaves a lot of the rest of us who can still write a letter, listen in, say one thing when your board comes up. So I'd really encourage people not to get overwhelmed by the amount of work, but remember, you can break it down. The old thing about eating the elephant one bite at a time. You don't have to fight your board all at once. You're not going to win all at once. You can learn about your members. You can reach out and have communication with your members. You can send a letter. Just 1 or 2 really simple things, I think can make a huge difference in this year coming up. Now, what I'd like to ask people to put in chat is what are the obstacles that's hindering the rest of, I don't want to say you, the rest of us from going forward? What is it that is keeping you from contacting your board? And if you can put in chat, what would help you? Would it help you if I wrote a sample letter? Would it help you if there was one-to-one work where you could be kind of guided through your first work with the board? Let me know in chat right now. What is your biggest obstacle? If it's your pain, that's fine. You can put pain. But if it's something else, like you don't know where to start, you don't know, you're not clear what the next steps are, go ahead and put that in. If you think sample letters would help, Yes, I do need the chat. So that would be really good. That would be really helpful to me. So go ahead and put that in, and then I'll take a look at that. Um, I think some of the key, it might help if there were key areas that we focused on for next year. Instead of just saying, let's go with the boards, we could look at maybe three top items, which would probably be, oh, write down what your top items are. I'm thinking shortages, MME limits, and MD fear of the board. If I had to pick three, please, why don't you put in chat, if you had to put three, what would your top three be? I think that would be really helpful to me. And that was my kind of looking back for the year. I think it's a great group. We have a lot of potential. We've already done a lot of good, and I really want to encourage everybody to say 2026 can be even better. We can make a lot more progress there. Mark, before I talk about the conference, is there anything you would like to bring up about the boards?
No.
Okay, good enough. Keep fighting, right? We'll keep fighting. Okay, with that, I want to turn it over to Monty Goddard, and he's going to be updating us on the California Pain Forum that we're going to be having December 17th. And Monty, are you there? I will turn it over to Monty.
Yeah, I'm here, Pat. Thank you. Let me read the title of this forum. Patients and Prescriptions, Addressing Challenges, Finding Opportunities. This forum, as we talked about last month, so I'm not going to belabor it, but it's primarily the result of something Kristen started years ago, and Pat and I have been addressing for the last 18 months with the medical board and the pharmacy board. We've got two issues. One is they haven't rolled out their guidelines. They've got pretty darn good guidelines. All of us worked on those guidelines when they got published. That was July of 2023. Subsequent to that time, Dr. Haddad had his experience with the medical board. Now, I brought that out to the medical board. This is not helping. What you're doing to Dr. Haddad looks to the world like you don't believe your own guidelines. We've called them on that. But then the other issue was the impact of the nationwide injunction on the supply of medications to pharmacies. We've been not beating up both boards. We've been professionally, politely, respectfully asking the two boards to get together and form a union to fight on behalf of pain patients the impact of these issues. With bottom line is the people that did this to us on the thresholds were the state AGs. The medical boards work with the state AG all the time. One of them going up might not be effective. Two of them going up might be. The bottom line is this: they now have 6 boards that are hosting this workshop on December 17th. The purpose of the workshop in the morning is going to be to lay the groundwork for what follow-on actions they intend to take, according to what they've told me. They are already planning interested parties meetings for 2026. So the morning part of this workshop is going to be to set the stage. What's the regulatory environment? Educate folks on the injunction. And then Pat and I's role is simply not to convince them on the scientific stuff that Red Lawhern or Mark Gibson or Dr. Tennant, but to tell the patient's story. What is what's happening today doing to the lives of patients? Pat's going to tell her story. I'm going to tell mine. In addition to that, we've got about a 22 slide package where we're going to go through and put them on notice. We're putting the medical board on notice. This is what's happening. You had published your guidelines. This is the reactions of people in California to your guidelines, including yourself. We point out what we think are some of the problems, systemic failure to change the culture that existed in years prior, like with their death certificate project. So we're pointing all that out. Then in the afternoon, then there'll be a lunch break. In the afternoon, there will be a panel. Yours truly is going to be on the panel with three other people. And last I heard, Kimberly Kirchmeyer, the head of the Department of Consumer Affairs, will be the moderator for the panel, and we'll be taking questions from the audience and back and forth. And once that's supposed to plan to take about an hour. After that, they're going to break up into workshops, and to address different issues that have been generated by the proceedings earlier in the day, including the presentations and the panel discussion. Once that, people who are attending this thing, whether they're in person or virtual, are supposed to have the ability to select the various workshops in that afternoon to participate in. At the end of the day, the thing I've been told, no recording will be released to the general public of the forum, but there will be an after action report with a list of action items that we interested parties, that includes pain patients and advocates, will be working on next year. How this thing works out, I don't know. I'm excited to be there. I want someone to hear my wife and I's story. There's going to be allegedly DEA folks in the room. I want them to hear my and my wife's story and what has happened to pain patients in this country. So I'm super excited about this. We put out invitations to folks in the community to see whether or not they'd be interested in attending either in person. I left that out. I should tell you. Initially, there were going to be no pain patients and advocates in the room or attending virtually, other than Pat and myself in person. I objected to that. The executive director of the medical board realized that, that's probably a legitimate objection. So we got permission for 15 in virtual and 5 in person. Pat and I are 2 of those 5. Currently have 2 vacancies still for in person, and we have 1 vacancy for virtual. If any of you folks that are listening to this tonight, send me an email tonight, because I'm committed to supply the list tomorrow morning to the medical board. If you send me the information before you go to bed tonight or before I get up tomorrow morning, I will submit it to the medical board. If you would want to attend, and I'll share my email address with you. It's real complicated. It's my name, Monty, M-O-N-T-Y, Goddard, Goddard, at msn.com. I'm going to turn it back over to you, Pat.
Okay. Pardon me. Thank you, Monty. Somebody asked where. It's in Sacramento, California. So if you're, that's okay. It's got to be somewhere. So
the doors open.
Hopefully.
Excuse me, Pat. The doors open at 8 o'clock. The actual program starts at 8:30. Yeah. So if you're attending virtually, you got to be there by, I'd recommend by 8:15 or so. And then there'll be an hour lunch break, and they hope to wrap up a little after 4 in the afternoon.
Thank you. Thank you very much.
That's one of Pat's alma maters. Go for it, Pat.
One of them, yes.
Sacramento State University.
It's Sacramento State University for my MED. That's it. I do want to say, if you aren't able to attend this, hopefully, well, not hopefully, we've started some momentum with the California board in that they are not promising, but talking about what they're calling a townhouse. Is that right, Monty? Am I using the right word? Of another forum next year.
Parties meeting.
What's that?
Town hall interested parties meeting.
Yes, for next year. So
Correct.
We will have more opportunity to have more feedback from the group. So if we've missed any really pertinent points, and even though that's not being recorded, you can bet Monty and I'll come and do a debrief for you so that you will be able to hear all the details. So we're not going to let this just drop. You'll hear a debrief, and then we'll let you know what next steps are we go forward. It is a huge opportunity, and I hope a little bit hopeful for people that you can see it is possible to move the board kind of in the direction we want to go. So really, truly don't give up. And we really appreciate everybody's.
Hey, Pat, I just realized there's one thing I missed.
What's that?
The attendees in person, there's going to be 200 folks. And other than the few pain patient advocates that I mentioned, the 5, all of those are going to be licensees of the sponsoring boards. And that's true for the virtual population. The pharmacists, both in person and virtual, are fully taken, as is the medical board in person and fully taken. Some of the other boards are not quite as interested, it appears, but there's going to be a pretty good population of folks that are going to hear all of those morning presentations, and that's valuable.
And here are stories about what real pain patients are going through.
Exactly.
Okay. Well, thank you. Well, Dr. Tennant, that is all Monty and I have for this evening. I'll turn it back to you.
Thank you.
Thank you
Pat.
so much. I'm very excited about what you and Monty are doing. And I think the California seminar will carry a long ways. I noticed several people flashed on the screen that they could use some sample letters. And I think that's well worthwhile. When you contact the medical boards, you don't have to be very articulate. You don't have to be detailed. What you got to do is be honest about it. Our concern about the medical boards is that we don't trust them. We have laws, we have regulations, we have common sense, we have experts, and the history is that these boards have been untrustworthy, and that people are fearful that they can't get treatment or their treatment will be taken away. And I think the California seminar will carry. So anybody, I don't care what state you're in, if you can tune in and help, do so. But I think the main thing the medical boards have got to hear is we don't trust them, and we don't trust them because of their past history. And there's a lot of new things out there too, and I don't think they keep up, okay, with new stuff. So anyway, thanks for what you're doing. I think we are making some progress. I really do. I sense that there's an awareness among boards that something's gone wrong, and I do think the boat's slowly turning around. So thanks for being there. We'll get a good report next month. Thank you so much. Jimmy, thank you for the show tonight. Mike, great show, great interview. Your method should be done by everybody. We'll sign off on that. Anyway, have a good holiday, and we'll see you next week. Good day.
Thank you so much.
Right.
Thank you, Dr. Tennant. And thank you, Pat and Monty. Thank you, Mike. Thank you to everyone that was here with us this evening. You are not alone. God bless you.
Good
Bye.
night.
Good
Good
night.
night, Jamie.
Thank you so much. Thanks, Pat.
Okay.
Good night, Jamie.
Monty.
Night.
Thank you,
Good
Mike.
night.
See, the best.
I'll stick around.
Thank you, Mike.
Thank you. Thank you. Glad to hear your story.
Good night. I have to go because I'm committed to a rosary group that prays every evening at 8. So I'm late, but they know why, because we pray for us. We pray for you, everyone.
Thank you,
So,
Donna.
I
Thank
love
you.
you. I will.
We love
I'll
you
see
so
next
much.
week.
We'll see you
Thank
next
you. I
week.
love you too.
We love you. God
Bye,
bless you.
Donna.
Thank you.
Bye-bye.
Hey,
Thank you
Donna.
so much. Yeah.
Donna,
Yeah.
I'm having a heart cath tomorrow, so pray for me, will you?
Say it again.
I'm having a cardiac angiogram, a heart cath tomorrow.
Okay. All right. Certainly. Well,
Add that.
I'll add that to
Thank
our
you.
intentions tonight. Thank you for letting me know, Doctor.
Thanks.
I will. We will pray.
Bye-bye.
Thank you all. I love you.
Love you,
Bye,
Donna.